Welcome, and thank you for joining us today for the New Directions in Implementation Science Integrating Multiple Interventions webinar. My name is Denise Ganip, and I'll be your WebEx host. Before we get started, I'd like to review a few WebEx logistics. This webinar is being recorded, and the recording will be available on YouTube and the IS website in the coming weeks. All lines have been muted upon entry and will remain muted for the duration of the webinar. Please submit your questions and comments by using the chat or Q&A panel and select everyone or all panelists. The moderator will ask them on your behalf during the Q&A discussion. You may need to activate the appropriate panel using the menu options found at the bottom of your screen. To focus on the people who are showing video during the meeting, go to View in the top right corner, click Hide Participants Without Video. And closed captioning is available by clicking on the CC button in the lower left corner of your screen. I'd now like to turn it over to Dr. David Chambers to begin the webinar.
Thanks so much, Denise, and thanks to everybody for joining us. We're very excited to be with you today and to feature a topic as part of a newer suite of webinars that we're interested in launching that are really focusing on sort of emerging areas that we see in implementation science. As you saw from the title slide, this is really about ways in which we combine our interventions. Rather than thinking about one intervention at a time, how do we blend, how do we bundle, how do we, at times some people refer to this as braiding different interventions together to more efficiently meet the needs of folks around cancer control. And so we're so delighted to have three incredible experts who are walking us through both sort of conceptually and then empirical work around how do we take these different evidence-based interventions and think about them in combination. So you see the smiling faces along with my own in front of you. We start out with Dr. Aubrey Villalobos from our team at the NCI. Aubrey has been such a great leader for us internally in helping us to think through the logistics and the concepts around how do we consider all of the different things that we need to deliver to support somebody through cancer control, and how do we more efficiently blend and bundle them together. Shannon Self-Brown next to her, I had the great fortune of meeting Shannon some years ago when she was doing some really important work in the sort of child welfare space. And so it's so great to see her, and thanks to her and her collaborator for donating one of their project to our online repository of funded grants. And so Shannon's really wonderful work in again, thinking about bundling different interventions together will be a great opportunity for us to learn. And then after Shannon, we have Vicki Champion from Indiana University, who many of us know as a luminary who's really focused on how do we bundle different screening interventions together, how do we really think about meeting the needs of diverse populations across dispersed geographical areas as well. And so grateful again to be able to turn it over to each of these three presenters. Encourage all of you, as questions arise, please do put them in the chat. We will go through the three presentations to get everything on the table in front of us, and then we'll proceed to a wonderful back and forth with our great presenters. So with that as the prologue, why don't I turn it over to Aubrey. Aubrey, please take it away.
Thanks so much, David, and thanks everyone for joining us today. I really welcome you and just thank you for your interest in integrating multiple interventions. Next slide, please, Denise. So this presentation is based on a commentary that David and I published late last year in JNCI Cancer Spectrum. Here's the URL and a QR code for you to get the full text, and I encourage you to check it out for a more in-depth discussion of what I'm about to cover. Depending on your generation, this is going to be the Reader's Digest or the Cliff Notes or Spark Notes version, so you can see the full text there. Next slide, please. So why should we consider integrating interventions? So one motivation for considering this is that the typical single disease, single intervention, siloed approaches that we have tended to develop are often not having their maximum potential impact. In part, this may be because people have multifaceted needs and because siloed intervention structures do not always align with how we deliver care in public health and clinical settings. So accordingly, there's really been a push towards more holistic and integrated approaches to better meet patient and community needs. Next slide, please. Another motivator for integration is that there's limited capacity in the health system to implement and sustain this ever-expanding number of interventions that we've been developing through research in parallel. So Dr. Chambers and I proposed two main pathways towards integration of evidence-based interventions, and each has different benefits, challenges, and decision points. So let's take a look at the definitions that we proposed. Next slide, please. So the first is a blended intervention. A blended intervention includes components from two or more evidence-based interventions, is focused on at least two behaviors or health topics, and is harmonized into a holistic intervention that is really no longer distinguishable as separate. The blended intervention aims to have enhanced implementation, client, service, behavior, or health outcomes compared to delivery of the original interventions separately. The components of a blended intervention are delivered in the same manner. And in the literature, some have used this term of systematic braiding as a way to construct blended interventions. So I like to think about them as smoothies. Next slide, please. Bundled interventions, a bundled intervention is really an approach to delivering multiple distinct behavior change or clinical interventions, either simultaneously or intentionally sequenced over time, and address multiple health or disease outcomes. So evidence-based interventions, again, are bundled with this aim of improving outcomes for multiple cancer types or other health concerns compared with delivery of the original interventions separately. And this maybe is a salad. Next slide, please. So now that we've looked at two proposed typologies of integrated interventions, let's consider how to select what interventions to integrate and whether they might be best blended or bundled. The funnel in this graphic here on the screen represents that there's this broad universe of evidence-based effective interventions from which we might choose. On this slide, those in the purple shades span the cancer continuum from primary prevention to precancer or early cancer detection to post-diagnosis. Those in the blue shades represent interventions from other chronic and infectious conditions, including primary prevention, testing and monitoring, as well as mental health. Next slide, please. So one of the first things to think through in selecting interventions for integration, it might be with a lens toward the intervention need or opportunity. Where on the cancer continuum are you working? Integrating multiple cancer prevention or early detection interventions might make sense. Similarly, integrating cancer prevention interventions with health promotion interventions targeting another condition might fit well together. However, if we think back to our motivation for integration and the definitions that we proposed, it might also make sense to integrate a health promotion intervention, say around nutrition or physical activity, with a cancer treatment or survivorship intervention, if that integration is expected to improve outcomes above and beyond delivering the interventions in isolation. It may also help at this stage to consider patterns of co-occurring behaviors and motivations when deciding which interventions to integrate. So, for example, motivations around positive health behaviors often correlate and reinforce each other. So integrating interventions around nutrition, physical activity, tobacco, and alcohol might work well together. And similarly, patients might be open to multiple vaccinations or screening tests if they're already proactively seeking out one of those services. Next slide, please. A second lens to look through when identifying interventions to integrate is delivery and workflow integration. So selecting interventions that are developed to be delivered at the same ecological level or context or setting or by the same implementer might make common sense for easy integration, right? However, while some interventions may have aligned motivations for health promotion, it may not be feasible to integrate them because the workflows are too divergent. In thinking about equity, integrating interventions that address or are influenced by shared social or structural drivers that could be a really good opportunity to advance equity-related outcomes. Considering the intended beneficiary of an intervention could also be useful at this stage. So integrating based on shared risk profile or population demographics will often make sense. But alternatively, there's some really creative integration that could reach multiple beneficiaries simultaneously and be really opportunistic, like some examples that we saw of integrated interventions that reach both a parent and a child with different services, but during the same encounter. Next slide, please. So the third lens that we propose for considering interventions to integrate is through community, patient, and partner engagement. The practice-based expertise that implementers bring and input from community members and patients is really critical to challenging and validating the considerations that I've mentioned already. This information can help determine what is feasible for adopters to integrate to best meet needs and streamline workflows, as well as what may be acceptable to end users. This input will also likely be essential to determining whether to assemble a blended or bundled intervention. Interventions that incorporate similar components and their delivery is supported with common implementation strategies may be well suited for blending into one holistic intervention. Whereas some cancer screenings cannot be delivered together, but could be bundled and supported through integrated strategies like reminder recalls and navigation for that intentional sequencing. Next slide, please. So 2 examples of blended interventions include delivering tobacco cessation along with lung cancer screening shared decision-making as one example, and the second as collaborative care for management of multiple cancer symptoms like depression, pain, and fatigue. And we just saw an article came out and the Cancer Currents blog covered it earlier this month. Another example, developed through the systematic braiding technique, blends secondhand smoke exposure reduction and child maltreatment prevention interventions. Next slide, please. 2 examples of bundled interventions are bundling screenings and genetic services for multiple cancers as one example, and shared care models of survivorship services, here including patient navigation, psychosocial health, palliative care, and nutrition and physical activity. You can see that each bundle involves a number of distinct evidence-based interventions targeting multiple behavior changes or clinical interventions, and they're delivered either simultaneously or that intentional sequencing over time, addressing multiple health or disease outcomes. So to close, I would point you back to the article for further reading on things to consider related to implementation that may be unique to integrated interventions, such as the pacing or sequencing of the different components, what implications it may have for the workforce and workflows, as well as cost-related questions. In addition, integrated interventions should be evaluated in an integrated way. So there may be considerations about challenges and opportunities related to assessments and data collection and analyses that you should consider as well. And next slide. With that, I will say thank you. I'll turn it over to Dr. Self-Brown now.
Thank you. I'm so excited to be here today to present on an integrated intervention that Michelle Kegler and I, along with our amazing teams, have developed to address secondhand smoke exposure among young children. And we're currently in the process of testing this integrated intervention in a hybrid trial as part of an R01 project funded by the National Cancer Institute. So to set the stage for today, I'm first going to just go over some information as to why we thought it was important to develop this integrated intervention. I'm then going to talk through the systematic braiding approach, which we use to develop the integrated intervention, and then I'll give you some updates on our R01 project. Next slide. So to set the stage, secondhand smoke exposure among children leads to poor health outcomes, and it is a preventable health threat. For young children, the most common place to be exposed to secondhand smoke exposure is in the home, and there are evidence-based programs that exist to reduce secondhand smoke exposure, but they have not had the opportunity to be well disseminated. Next slide. So as David said in the introduction, I am a child maltreatment researcher. I spend most of my career working on efforts in implementation science to address child maltreatment prevention or child mental health challenges that may result from trauma. And one of the things that our team was learning as we conducted effectiveness trials of child maltreatment prevention interventions is that daily tobacco use is much more highly prevalent among parents who are involved with child maltreatment prevention programs than in the general U.S. adult population. And so evidence-based child maltreatment prevention programs have had the opportunity to be widely disseminated. The programs are typically delivered in home visitation approach, and they address child well-being and child safety, and they reach more than 250,000 families a year in the U.S. Specifically last year in 2023, they reached approximately 278,000 families, and this dissemination was really supported by the Affordable Health Care Act and reauthorized legislation since that act. So because there was a need to think about secondhand smoke exposure amongst parents who were engaged in these child maltreatment prevention programs, and they are widely disseminated, we thought this might be an important service strategy dissemination approach by which we could increase the reach of secondhand smoke exposure prevention programs. Next slide. So this brings me to the aims of our current R01 project. Its aim one was to work on the systematic braiding of the smoke-free homes intervention, which was developed by Michelle Kegler, and the Safe Care intervention, which is the child maltreatment prevention intervention that I do most of my research on. And we wanted to braid these into an integrated program, so more along the lines of the smoothie analogy that was just given, and really be able to deliver this intervention within ongoing Safe Care implementations that are occurring across the U.S. Our second aim was to evaluate the impact of the Smoke-Free Home Safe Care program on smoke-free home rules by parents as well as parenting outcomes, because we wanted to make sure that as we were rolling out the additional curricula that we were not diffusing the outcomes that Safe Care has on the modifiable risk factors for child maltreatment. And last, our aim 3 focuses on process and implementation outcomes for the Smoke-Free Home Safe Care intervention as compared to our standard Safe Care and ongoing implementations. Next slide. So to just give you a little bit of context, I'm going to briefly go over the Safe Care intervention and the Smoke-Free Homes intervention. The Safe Care intervention is a home visitation program that targets parents of young children ages 0 to 5 and has 3 very structured modules. The first is parent-child interaction, which also has a parent-infant interaction curriculum. And the goal of this module is to focus on strengthening the relationship between a parent and child, as well as to reduce challenging child behavior problems with the hope of reducing the risk for physical abuse and neglect in families. The second module is home safety. In this module, we engage with parents and we work to reduce home hazards, and we work with parents to appropriately supervise their young children according to child development. And the goal of this module is to reduce unintentional injury in the home. Lastly, our third module is child health, and in this module we work with parents to engage them in effective decision making in response to common health and illness situations that a young child may experience in order to reduce medical neglect risk. Next slide. So this program is delivered in 18 weekly sessions, so it takes a little over 4 months to deliver, and each of those 3 modules, parent-child interaction, health, and safety, are 6 sessions. And in each of the 6 sessions for the modules, there is an assess, train, assess approach that is very structured with a provider manual that gives detailed step-by-step information about how to deliver the session to families. Next slide. For smoke-free homes, some things are better outside. This is Michelle Kegler's program. It is a very light touch program to increase smoke-free home rules in the lives of families. The intervention includes 3 mailings, and they're mailed over a 6-week period, and 1 coaching call. The coaching call lasts between 10 and 20 minutes. The mailings include information for how secondhand smoke exposure can be dangerous to the health of young children, and also encourages ways and provides materials to enhance smoke-free home rules in the home setting. And the coaching call is meant to really work with the parent according to the stage of change that they're in to set goals for either creating a smoke-free home or a plan to implement smoke-free home rules over time. And it is an evidence-based program listed on the EBCCP. Next slide. So for the aim 1 of our project, we engaged in the systematic rating approach, which was developed by Kate Guastafaro, and we followed the 5 phases that are designed for this particular approach. So in phase 1, we engaged in cross-training of our 2 teams in the intervention and identification of core elements of each of the programs. In phase 2, we engaged in expert development of an integrated curriculum. In phase 3, we engaged in acceptability and feasibility pilot work with end users, which in this case was Safe Care parents. In phase 4, we worked to modify the smoke-free home Safe Care curriculum and refine it with our stakeholders who are Safe Care providers who are working in an ongoing Safe Care implementation. And phase 5, which we are in currently, is wide implementation of the braided curriculum, which we are currently testing across 9 states, and we'll hopefully be able to disseminate it more broadly if we find that it is effective in this trial. So let me take you through each of these steps in a little more detail. Next slide. So here's the phase 1. So this table really guides the 2 intervention developers in a process of identifying shared elements. And this is really important to helping you braid the intervention in a way that makes the most sense for delivery and also recognizes the implementation protocols and processes that are imperative to ensuring that the mechanisms of, that are driving the outcomes remain included in the program. So we were really excited when we engaged in this exercise because we did find a lot of shared elements of the 2 programs, including who we target, which is the parents of young children. Both could be delivered in the home setting. The timing of our programs really aligned well because the smoke-free home program is delivered across 6 weeks, and that aligns perfectly with the Safe Care modules that we have that are part of the program. And we both included program evaluation in our program delivery, as well as had a focus on fidelity monitoring. We also had a similar theoretical framework for the work. So all of these things allowed us to integrate in a more seamless way than if we had had a lot of differences probably in this phase. Next slide. So for phase 2, this was the expert development of the integrated Safe Care. So prior to the grant submission, we conducted phase 1, which I just described, and this phase 2. And so our teams, really looked at the 2 interventions and thought that the smoke-free home materials could fit into any of the Safe Care modules, and that the way that it would be delivered is that in session 2, when the home visitor comes into the home to deliver Safe Care, they could pass along the materials that are typically mailed to the parent directly. Then in sessions 3 and 4, we split up what was typically the coaching call for 10 to 20 minutes, and we have a touch point of that coaching call, what was formerly the coaching call, in session 3 delivered by our Safe Care provider, and in session 4 delivered by the Safe Care provider. And then in sessions 5 and 6, the Safe Care provider delivers those, what were originally the mailings, as smoke-free home kits in session 5 of the Safe Care module and in session 6 of the Safe Care module. Next slide. So when we got the grant, this is when we, were intending to move to step 3, which is the piloting of the integrated curriculum. But as we started gearing up to pilot, we realized we had a little bit more work to do, so we kind of had a step 2.5 in our systematic grading that took us about 3 months to do. We really needed to get much more granular in how we designed the protocol for our Safe Care providers to deliver the smoke-free home integrations. And so we developed a small team of our clinical specialists, Safe Care clinical specialists, smoke-free home clinical specialists, and they really worked on braiding the curriculum content in a way that would be meaningful to Safe Care providers. And then we began the pilot process with families that were recruited who had a smoker living in the home. And we had 2 providers trained. They delivered the integrated intervention to 4 families. It had gone well, but they noticed that a few more tweaks needed to happen to ease the delivery. And so we made a few additional changes to the curriculum and then completed the pilot with the parents from there. Next slide. So this is just an example of how the integrated intervention looked. So Safe Care has a provider manual that has a step-by-step detailed information about each thing that a provider should do in a session when delivering Safe Care. And we simply integrated the information for Smoke-Free Home into the Safe Care provider manual since our trial was going to be taking place in ongoing Safe Care implementations. And the next slide has another just example of how we integrated the smoke-free home into the Safe Care provider manual. And we did this because we knew our providers were already comfortable with this manual, and we wanted to just make sure that the delivery process made sense to them and felt familiar to them. Next slide. So in our pilot work with the 8 families, we did see an increase in smoke-free home rules and a decrease in parenting stress, which we were excited to see that as we had more content in the intervention, it did not diffuse the parenting outcomes that we typically see in the Safe Care program. We did qualitative work with our parents, and we heard overwhelmingly positive feedback from them on the content of the smoke-free home materials, as well as the fact that they were very comfortable talking about creating a smoke-free home with their provider, which we were excited to hear about. Next slide. So we then took that curriculum and we disseminated it to our Safe Care providers, 10 of them who are working in ongoing implementations. And we had them look at the materials for 2 weeks, and then we did a qualitative interview with them to get their feedback on the materials, suggestions, and thoughts. And so when we did our interviews with the Safe Care providers, they encouraged us just to have the smoke-free home materials in the child health module and in the home safety module. They did not think that the materials fit or aligned as seamlessly in the parent-child interaction module. So we did just conduct the braid for those 2 modules, and a provider can choose which module they want to deliver the smoke-free home materials to the family in. So it gives the provider some choice over that. We heard a lot of good information about feasibility and acceptability of the materials. The providers also thought that there was a critical need to build strong rapport with clients before launching into topics about tobacco use, and so we really made sure to encourage this information as part of our workshop for the smoke-free home Safe Care. One of our favorite quotes was having materials about secondhand smoke prevention already integrated so we don't have to pull resources ourselves is so helpful. A combined intervention is a double win. And so providers were addressing this issue while they were delivering Safe Care, but they were just pulling their own materials. And so by providing an evidence-based curricula integrated, we really solved that problem and can feel more confident in addressing this topic. Next slide. Okay, very quickly, where we are now is we do have our AIMS 2 and 3 underway in an effectiveness implementation hybrid trial type 1. We have recruited 50 Safe Care providers that are either randomized to Safe Care or smoke-free home Safe Care, and we're recruiting 500 families and looking at outcomes at the family level as to whether a smoke-free home rule was established, and we're verifying that with air nicotine monitors. We're continuing to measure parenting outcomes, and we're measuring implementation and process outcomes. We want to understand, does this additional curriculum challenge provider fidelity? What are the costs? We know there's additional training costs and delivery costs when you add more curriculum to deliver, and we want to understand if there's benefit to those costs, and importantly, what's the impact on parent engagement in addressing topics such as smoking in the Safe Care program. Next slide. So lastly, if we find that the integrated intervention is effective, we have a pretty seamless way to disseminate these efforts because we have more than 150 accredited safe care agencies across the U.S. that reach more than 8,000 families a year. So to disseminate this, I run the National Safe Care Training and Research Center along with Dan Whitaker. We simply could offer trainings in smoke-free home rules to our existing safe care providers. We've been able to train in the smoke-free home safe care content in about 2.5 hours with 3 follow-up touchpoint coaching sessions. So it's a pretty low burden training. And ultimately, if effective, then this would allow for broader dissemination of secondhand smoke exposure prevention efforts, through a service strategy that reaches hundreds of thousands of families a year and could help eliminate cancer disparities. So that's really our goal. Thank you so much, and I'll turn it over to Dr. Champion.
Thank you. I'm delighted to be here this afternoon, and I'm going to report on a study that is finished and is in process of publishing several papers. It was supported by the National Cancer Institute, an R01 study in collaboration with Ohio State and my co-PI, Dr. Electra Pasquette. Next slide. The study aims, very briefly, and this is a synopsis, were to develop interventions to improve uptake of cancer screening for women in ages 50 through 74 in rural Ohio and Indiana. And I will talk about the rationale for both interventions, development, and the problem in just a minute. So the 3 screenings that were recommended, other than lung cancer screening, which is for a specialized population, are breast, cervical, and colorectal for women. We selected 2 interventions, tailored DVD intervention, tailored messaging delivered via DVD, and a DVD and patient navigation. The reason for this is a lot of my work has been done with tailored messaging using different media to increase screening on breast, cervical, or colorectal cancer. Dr. Electra Pasquette has used patient navigation to do the same thing with screens. So we decided, to see in a minute, to test these 2 interventions and see how they collaboratively and bundled increased screening for any or all of the needed cancer screening tests. So these interventions encouraged women to get the needed screening tests, and we had to identify what those were to begin with. And we checked medical records both to confirm eligibility in terms of women needing at least one of these tests and actually having the test 12 months after the intervention. We also, and I'm not going to talk about this, but it is in the key paper, wanted to determine if the interventions were cost effective to deliver. Next slide, please. So every good research project starts with a problem, right? So when looking at, and this is an example of a bundled intervention, we were challenged to look at the cancer screenings that had a problem in rural Indiana and rural Ohio. And we found out that the rates were lower for screening for all 3 recommended cancer screenings, breast, cervical, and colorectal. And the incidence and mortality rates, which follow the screenings, were higher in these rural counties. We looked at the deprivation index, which is a separate paper, and I'm not going to really talk about because Appalachia was included in some of these counties in Ohio. Next slide, please. So we had 3 arms: usual care, a tailored DVD, which was extremely complex, which I'll talk to you about in a minute. Complex to develop, hopefully not complex for the women to assess. And then an arm in which women were mailed the DVD, and after a period of 2 weeks were contacted by a patient navigator to address any barriers they might have to a cancer screening for which they were not adherent. We stratified by age, looking at women 50 to 64 and those 65 to 74. Now, we assessed or delivered interventions tailored to what the woman needed. And they could have been in any one of these 7 categories. They could have been non-adherent to breast, cervical or colorectal cancer independently. They could have been non-adherent to breast and cervical, breast and colorectal. All three are cervical and colorectal. So there were really 7 categories here. We were faced with the challenge of identifying which category women fell into because we wanted to deliver an intervention consistent with what they needed. Next slide, please. So if you just look at the first column here, I wanted to give you an idea of the percentages of women that fell into each of these categories. Those who needed all 3 screening tests were about 19% of the total sample, which was 963. Those who needed breast and colorectal included about 9.2%, breast and cervical, 7%, cervical and colorectal, 13%, breast only, 6%. That was the one that had the highest adherence, as you might have figured out. And colorectal, 27%, cervical only 18%. Colorectal was the one that had the most problems. Next slide, please. Okay, the DVD development, tailored DVD development, was challenged with identifying what category women were in, what tests they needed to be adherent to, and delivering tailored messages that related to those specific tests. This was an interactive DVD, and you might wonder why DVD, why not an internet intervention, which we had done with other populations. We found out at the time this was done that the internet coverage in these areas was very low. However, the DVD, everyone in the rural areas that we talked to had a DVD and used DVD players. So the tailored program was developed based on a DVD format. This is a diagram of the DVD as it was developed. It was interactive. Women were given only the program for which they were non-adherent. And again, there were 7 categories, which I think I went over. Next slide. The main results are published in JAMA Open Network, and I'll just very briefly go over these as I go through the slides. Next slide. So overall, 80% of the women were up to date with all cancer screenings at 12 months. And for any cancer screening, 67%. I'm sorry, I read that wrong. 20% were up to date with all cancer screenings based upon our intervention. 80% were not up to date. And 36% were adherent to any cancer screening. Next slide, please. In terms of adherence to any cancer screenings, the DVD plus patient navigation arm increased the rate of adherence by almost 6-fold. The DVD alone by almost 2-fold. And they were significant. These results are published in the paper I just saw. We are also analyzing the results with breast alone, just women who needed breast cancer screening, and with colorectal cancer screening. The things that we found that were different with these and looking at whether they had had any cancer screening or all cancer screenings were that for both breast and colorectal, women who intended to have that screening were adherent within the next 6 months. And women who had received reminders were adherent and who needed only that test. Next slide, please. These are the conclusions for the colorectal cancer paper, which will be coming out soon. Summary slide. Next slide, please. Okay, so in summary, there was overwhelming agreement, and we did a process assessment several months after the interventions were delivered, that the DVD was easy to understand, helpful, and provided trustworthy information. All participants had a DVD and had no problem with using it. And that it gave participants only the information they needed to make a decision about the cancer screening they needed. There was a median of 4 navigation encounters per participant after the navigation was started for the women in that arm, and the calls lasted about 15 minutes each. Women often over-reported screening, and that's why we went to medical records, both to assess whether they were eligible to enter the study, and eligibility again was they had to be non-adherent to at least one of those 3 tests. It could have been any combination, but at least one. The DVD arm participants were almost twice as likely to be up to date with all cancer screenings compared to usual care, but the DVD plus navigation participants were almost 6 times more likely to be up to date with all cancer screenings compared to usual care. And residents in areas of high deprivation were less likely to become up to date for all needed screenings, which is something we all know is a problem. So I will stop there so we can go to questions.
For the moment, I'm seeing that there are already some really wonderful questions in here, and maybe I'll just start with both of your there's a couple of questions that I think speak to the selection of these different interventions. And I guess I'm curious for your insight. So, so one of them in particular talks about, should we be drawing upon proven, acceptable, and efficacious interventions and think of those as the bundle versus, really trying to consider creating a new multi-component intervention where maybe the primary focus would be on testing the effectiveness of that intervention versus bundling and then implementing. So any thoughts that Aubrey and Shannon that you have on how do we consider what to bundle? And
yeah. So I'll just say to the multi-component comment, that was something that we talked about a little bit in the beginning of the article in terms of thinking about the what is it that we're looking at, blending or bundling and implementing, and, try to propose definitions for these integrated interventions that were distinct from a normal multi-component public health intervention that may just be focused on a single health topic or, disease area or behavior. And so with the integrated ones, I think ideally, you could work from scratch and develop, a multi-component intervention, but what we're really talking about is addressing multiple health concerns or behaviors or disease areas within, an integrated intervention, rather than like a normal multi-component intervention that we, see often that is really focused in one area with multiple components.
Great, thank you. Shannon, what do you think?
Well, in our case, I had identified a challenge that was specifically emerging in the child maltreatment prevention field, and I thought there must be evidence-based programs that exist that address this, and I was very lucky that there were, and that I found a purveyor of a program who was interested in kind of going on this journey together, and so that really made a lot of the, I think, the developmental work a little more seamless. But, and I think that with having the 2 established programs going through the systematic grading process is really designed for that. I do, however, think that if there aren't existing evidence-based programs, or it makes more sense to think about, perhaps programs that are developed but don't have a strong evidence base now, then you could think about using a multi-phase optimization strategy, a MOSE strategy, to sort of test those components and do the testing along with the integrating of the interventions.
So let's get, if we can get everyone back on camera, that would be lovely. And encouragement, certainly, to keep putting these wonderful questions in the chat so that we can take them on. One of them, I think, actually relates, Vicki, to the slides where you walk through, in a sense, 2 different types of outcomes that were related to a particular intervention, and then some sort of idea of a composite outcome. And the questioner really asks about, for all of your advice, that sometimes trying to figure out a composite measure may be challenging for reviewers who are used to seeing a discrete outcome. How do you navigate through this idea with this bundle of seeing a sort of bundle-wide outcome versus the sort of component-specific one? So, Vicki, do you want to start out?
That took multiple sessions with our statistician and team. I cannot tell you how complex the decision was for our main paper outcomes. And we decided to look at, because we actually wanted women to be adherent to all You know, women may have come in with adherence to 2, but we wanted to get that 3rd. So the optimal was adherence to all. So that was the primary outcome. And then the secondary one was, well, if they became adherent to one for which they were non-adherent at entry into the study. And those were 2 main outcomes. We are analyzing separately women who just needed breast, who needed colorectal, and in the midst of cervical. But that was extremely difficult.
Yeah, no, and I can imagine just from a population standpoint, if you have a bundle, there are going to be different segments within the population who may need the full bundle, who may need pieces. Right?
There were 7 categories of women. Those who needed cervical, breast, or colon only, and then the combination, as I showed in the first one. And colorectal was the one that was most frequently non-adherent, breast most adherent, and cervical in the middle.
Gotcha. And so Shannon, turning to you, similar question. How have you been trying to navigate this idea of bundle-related outcomes versus the individual health outcomes? You're talking about childhood maltreatment. You're talking about, certainly smoke-free housing, et cetera.
Yeah, I mean, we really conceptualized our outcomes to focus on the smoke-free home and the validated air nicotine monitor of the smoke-free home rules. And then we couched the child maltreatment outcomes as secondary outcomes, really just within the context of there is meta-analyses in child maltreatment prevention research that shows that the more specific a program you have, the more targeted program you have, the more likely you are to have an outcome, and the more you add and add and add, the less likely you are to see outcomes. And so we didn't want to land in a situation where we had braided in this intervention and we ended up with an intervention that hit the mark on smoke-free home rules, but then we lost all the impact in child maltreatment prevention. So with these 2 separate outcome foci, we didn't come up with a composite outcome, but we really just contextualized them in terms of primary and secondary outcomes.
Gotcha. And then Aubrey, as you've been scanning through just different approaches that you've seen folks use, any patterns that are emerging? Is there anything that folks should know about these kind of decisions?
Yeah, no, I mean, I think that there's not a whole lot to synthesize across yet. I just will say that it is something that we encouraged in the article, in terms of people evaluating things in an integrated way. I think there is value to assessing both kind of the independent and combined effects, looking for, interactions across. And I think, for either blended or bundled, it's probably helpful, like if you think about down the line, if there's something that, you want to kind of get rid of, like it's helpful to know which parts, had the greatest outcomes and things like that. If you think about like resource economization, down the road or whatever. So I think it is helpful. I can't speak to how well it fares in review, but, I think we did also encourage, that there are opportunities for research in measure development to improve these techniques for, both data capture and how to best disentangle some of the effects. So, I think there's just opportunities there, but no answers. Sorry.
Yeah, and it looks like I'm just seeing in the chat that there's maybe this is a sort of a related question around outcomes, but that there may be, even if the primary, well, here's the question about tobacco-free homes and assessing environmental risks for asthma. So even extending to different health outcomes, so Shannon, when you're thinking about the range of different things that would be a consequence of exposure, how does that factor into your choice of outcomes?
Yeah, we really just, for this project, we used Michelle Kegler and her team's work for the types of outcomes that they had focused on with their smoke-free home program. And certainly there are a variety of health outcomes that the intervention may impact either directly or as a downstream outcome of having a more healthy overall family environment. But I think that that's certainly a very interesting and important question, and a way to really, I think, maximize understanding how these blended interventions are truly impacting a population. I think we're so used to, as public health researchers, as you know, we've discussed earlier, really focusing in on one thing well. And so this is a whole new area of thinking about how do we not only blend these interventions and think about the one or two outcomes that really are the focus, but how do we measure ultimately all the health factors that we are impacting, because that certainly would have a tremendous cost benefit if we could understand those.
Sure. And so maybe in that vein, would love to hear from Vicki and Aubrey and then you, Shannon, if as you think about the work that you've been doing in this space, what's rising to the top of like the next key challenge that you see us as a field needing to take on related to this effort to blend, to bundle our different interventions? Vicki, any thoughts you have about what do you want to see people do? Oh, I think you're on mute. Yeah, Vicki.
The next wave, which we're already into, is implementation of whether it's a single intervention or a multiple intervention. I'm working now on implementation of colorectal cancer screening with clinics in rural Indiana. It would be extremely difficult to take the bundled intervention that we completed to the clinics at this point in the way they conduct care. So I think that's going to be the biggest challenge.
Gotcha. Great. Aubrey?
Yeah, I mean, I think, you know, what we've found so far is that there's just not a whole lot going on in this space in cancer specifically. I think there's, you know, some work in integrating interventions in other areas, but in cancer, I'd love to see just more. And to Dr. Davis in the chat, I would just, you know, encourage continued persistence, because I think we need to be creative about how we can, you know, do more with less, and, you know, but we need to study that and know, is it equally effective or more effective? Is it efficient? Is it cost effective? You know, is it working? And so I think the two examples that we shared today really aligned well with, you know, some of the considerations that we put forward about both how to combine things in a, you know, blended or bundled intervention, you know, but also how to study them. You know, Dr. Self-Brown mentioned the, you know, the most, you know, designs. She's doing a hybrid type 1. That is exactly what we said, you know, is probably called for with blended interventions. So, you know, I think we just would love to see more work in this area so that we can know, you know, what impact it might have.
Great. And Shannon, what do you think?
I think continued work, much like Dr. Champion talked about today, that does incorporate technology. We did not in our projects. Everything is human delivered, and so there's a lot of training components that are very cumbersome and costly, and if these kinds of additional interventions could be delivered via technology, then we could simplify on the training aspects. And I think just any way that we can think about staying very relevant in the work. I mean, we never knew when we started this project that we were going to be going through a very long pandemic, and that a lot of our delivery of our safe care intervention would have to be delivered virtually in the first couple of years versus in person, and how that impacts outcomes. And then, you know, also just the emerging changes of public health issues. So in our parent population, it's not only tobacco use now, marijuana use is very, very common. And many of the providers that we train say, well, what should we be saying about marijuana smoke, and how do we incorporate this in? And so just, you know, flexible designs that allow for important development on the spot to be addressing those pressing issues, which is always tricky in a research trial that you want to have rigor in. So.
Yeah, absolutely. Great ideas, everybody. So I know we only have a couple minutes left, and I want to sneak in one last question, recognizing that folks on this call listening to the webinar are at a range of different stages in their career, and particularly for early stage investigators who are interested by this and really wanting to jump in, any advice that the three of you might have for where to start? And Shannon, maybe one thing would be, your grant to take a look at, and others. But Shannon and then Aubrey and Vicki closing us out. What advice do you have for folks who are newer to the field?
I think looking for training opportunities. We'll be at the Society for Prevention Research next week, and we're doing a whole session on systematic braiding across different, health outcomes and health issues. And you reach out. I mean, we have all been early career at some point a long time ago, but certainly remember that phase. And so just reach out to people who are doing work that you're interested in, and it may result in a good conversation and good collaboration.
Awesome. Aubrey.
I would say talk to the experts who are NIH funded with doing this type of work and really being leaders in this area. And I would also say, if you're thinking about submitting for funding, definitely reach out early and often to your program officers at NCI or elsewhere. Happy to talk through ideas.
Great, thanks. And Vicki.
Can you hear me?
Mm-hmm.
My computer keeps switching back and forth to unmute. So I think part of the responsibility a lot goes to the senior investigators. We need to reach out and bring the new investigators onto our team, which I always do, and they learn from working with us, and then senior investigators supporting them as they train as new faculty or even postdocs. It has to be a collaborative effort between people who have been through this and know the ropes, and new investigators, and support for them.
Awesome. Well, thanks to the three of you for your generosity of spirit and wonderful expertise that you're sharing. This has been great. I think we'll turn things over to Denise to close us out, but really appreciate your wisdom and everybody's attendance on this. So Denise, take it away.
Yeah, absolutely. So an archive of today's session will be available in the coming weeks on the IS website. I added that into the chat if you want to save that and bookmark it. And we look forward to seeing you at our next IS webinar. That wraps it up for today. Thank you very much.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.